Bush. I'm a practicing naturopathic doctor and the owner and operator of the Neurovana company. Neurovana is a leading provider of the medical breath testing services and SIBO support. Today, we're presenting the webinar, SIBO-Liver-Estrogen Dominance Connection, presented by me. Just a little housekeeping before we get started. If you have any questions during the presentation, please type them into the question box in your Click Meeting control panel. If possible, I'll bring them up during the presentation. Otherwise, I'll address them at the end of the presentation. A recorded version of this webinar will be made available on our website. Feel free to share it with your colleagues. Now, without further ado, well, let's begin this presentation. So, first off, I'm not going to bore you with about who I am. This is me. I am currently a practicing naturopathic doctor in beautiful Stillwater, Minnesota, where we also set up our SIBO laboratory. Myself and my wife, we started Neurovana because we had seen such an incredible response from testing and treating SIBO with our own patient base, and because we love laboratory and love interacting with people and helping people, we decided to try and spread the word about this and to provide an excellent low-cost service so that we can get people tested and treated for some of their root cause problems. I currently am still, of course, living here in Stillwater, and I do have 4 daughters. So this topic is near and dear to my heart because, well, I live with a lot of women, and therefore it's nice to know some chemistry. So first off, attendees of this lecture will have a better understanding of SIBO effects to the gallbladder and the liver, be able to diagnose SIBO as a cause behind estrogen excess, have a better appreciation of the genetic contributions to estrogen dominance and SIBO side effects of anxiety. Learn how to get more training on the topic of SIBO, which is part of what we're doing this whole spring. We have a 3-part webinar series that we're providing after this webinar. So each and every Wednesday for the next 3 weeks, we'll have our Introduction to SIBO Part 1, 2, and 3. Our original SIBO Part 1 webinar was recorded and is available for download and viewing from our website. So feel free to check that out if you have not already. As I mentioned before, we have a master SIBO class being started with our part 1, 2, and 3. So every single Wednesday for the next 3 weeks, we'll be offering a crash course on SIBO, and this is going to help in reinforcing some of the things that you've already maybe incorporated with your patients, and you might also learn a few other new tricks. So what are we going to be talking about today? We're going to talk about a lot about how liver health is essential for hormone balance, how gut health impacts liver function, how the estrogen detox does not address root cause problems. So if you're just doing an estrogen detox, estrogen balance in patients, sometimes you're kind of missing the root cause behind the imbalance to begin with. And look at a few of the genetic predispositions to estrogen excess and anxiety, which we see these combined together so frequently with my own patient base, and they overlap in also in how you treat. So we'll be focusing a lot on that today. Just a little basic things. I'm going to assume most people attending this lecture or watching it know something about SIBO. We're not going to be talking about the basics of SIBO here, but once again, some of the classic symptoms of a small intestinal bacterial overgrowth are often recognized as nausea, flatulence, bloating, diarrhea, halitosis, constipation, and malnutrition. Some of the extra GI symptoms that occurs that we see on a regular basis with patients suffering with SIBO include the muscle weakness, the joint pains, brain fog, anxiety, insomnia, headaches, heartburn and GERD, neuropathy, and skin rashes. SIBO is common in a lot of health conditions. In the general population, if you just grab anyone who has no health problems, they have between a 0 and 20% chance of having a SIBO overgrowth. But when you look at other conditions, things like celiac disease and ulcerative colitis and fibromyalgia, we're looking at very high incidence rates. For example, like with fibromyalgia, at 93% correlation between SIBO and the condition, you have to prove to me you don't have SIBO if you have fibromyalgia. And just as a little side note, my very first SIBO patient was a patient with chronic fatigue and fibromyalgia, and that was my big eye-opener, to completely wipe away most of the fibromyalgia with a single treatment of the gut was a big eye-opener. And in addition to that, the question is why can SIBO have such an impact? Well, when you start layering in all different situations that affect every single person, you have your SIBO, you have people's gut barrier integrity, all the different bacterial toxins that are created by your gut flora, the neurotransmitters that imbalances that can occur from both the gut flora activity and also the chronic inflammation that's created. Inflammation itself, it can be created both systemically but also locally. And this is always a little side note here. You know, when people do workups on patients with SIBO, the patients are often told they're healthy as a horse. There's no highly sensitive C-reactive protein elevated. Well, yeah, because a lot of times, a lot of that activity is stuck in the gut. And so testing for inflammation systemically often comes up without a test, without a positive. But if you do something like a myeloperoxidase, something that's more specific to neutrophil activity, it oftentimes does come up positive. And of course, genetic predispositions. You layer all these things with a patient with a active SIBO, and there's a lot of symptoms that occur. And in that, you know, when you have bacteria growing all throughout the small intestines in levels that they're not supposed to be in. So for example, I mean, you're supposed to have 17 times more bacteria in the large intestine than the small intestine. And in some of the cases that I'll be showing you and with some of our patients, we have patients with 10, 12, 14 times more bacteria in the small intestine than the large intestine. And all that bacterial activity, all of that huge mass of biological activity that is eating food is also secreting metabolic waste. And when the bacteria basically poop, creating a bunch of metabolic waste, the body has to respond to that. And that's where a lot of the secondary issues with SIBO comes into play. And this is a nice illustration where throughout the gut, when all that bacterial toxins are released, you have effects both in the brain and also in this particular case with this lecture topic, the liver. Now, in the brain, when you have a state of chronic inflammation, when you have some malabsorption, that's going to lead to just a reduction in neurotransmitter synthesis to begin with. But you also get a large production of ammonia, D-lactic acid, and many other metabolic waste products. And those metabolic waste products by themselves can change brain function, often resulting in not only fatigue, but also a lot of that brain fog that occurs. In addition to that, all that metabolic waste that is being produced in the liver or in the small intestines is then eventually dumped into the liver for processing. And when you have SIBO, SIBO can lead to a lot of side effects stemming from the liver, from liver dysfunction. Fatty liver, non-alcoholic fatty liver, even alcoholic fatty liver. Obesity can lead to fatty liver, and there's lots of studies showing a correlation between SIBO, obesity, and fatty liver. Bile stones, estrogen excess, of course, symptoms like PMS and PCOS. So what we're going to talk about a lot today is linked to the fact that the small intestinal blood flow, all that blood going through the small intestine and the colon, is directly pumped into the liver before it goes into systemic circulation. And that's a really important thing to conceptualize, because people always kind of wonder, if I have a SIBO, how does that affect my estrogen balance? How does that affect my ability to detox? And how does that affect my gallbladder function and vice versa? The thing to always remember, the small intestine, the large intestine, it's a big old tube, and it is wrapped with one of the largest portions of our circulatory system, and our immune system, and our nervous system, and all that blood flow is being pumped through. It picks up, on a normal basis in a healthy person, a lot of metabolic toxins and waste. You don't want that to circulate freely into systemic circulation. That's a poor quality blood. Hence, it's pumped right into the liver in order to be cleaned, and then can be pumped out to the rest of the body. So going back to sort of like in the published literature, the published literature is really great when it picks up on the extremes. And in the realm of hepatic fatty liver, both non-alcoholic and obesity-induced, you have SIBO as becoming a more and more recognized anomaly. So SIBO has been shown to induce a fatty liver in animal models, poor animals. We're sorry that you sacrificed yourself for the research, and I would never have done that research, but I am talking about it. We also know that studies have shown between 50 to 78% prevalence rate of SIBO in patients with a non-alcoholic steatohepatitis. We've also seen that the presence of SIBO has been associated with an increased risk of and the severity of non-alcoholic fatty liver disease in obese people. And that non-alcoholic fatty liver disease in humans is associated with increased gut permeability, and that this abnormality has been related to the increased prevalence of SIBO in these non-alcoholic fatty liver disease patients. And of course, you'll probably say, well, I don't see a lot of fatty liver disease in my practice. But one thing about published studies is that there's a mechanism here that we have to respect. And the big take-home for the connection between fatty livers and SIBO is that you have a significantly higher prevalence rate of SIBO in patients that end up having liver dysfunction. And it's not a coincidence. In addition to that, one of the main, the one condition that Medicare will cover for the prescription use of rifaximin is non-alcoholic fatty liver. Rifaximin is a treatment for it. I don't think it's a coincidence that it's also the treatment for SIBO. And that's something that we need to take home, because once again, in integrative medicine, we often start with the gut and liver as some of the core therapies that we start working with patients with. What's I think is essential is to always make sure that we identify as close to the root cause as possible with these patients, so that our treatments can be efficient, effective, and efficacious ultimately for the patient. So when it comes to estrogen metabolism, estrogen is metabolized for the most part in the liver, and it's up to the liver to be healthy enough to have proper metabolism of these molecules. If it does not, you'll have circulation of abnormal levels of not only the primary hormone, but also of its metabolites. And when it comes to estrogens, especially with estradiol, when estradiol is metabolized in the liver, it creates a number of metabolites, and some of those metabolites are more biologically active than the estradiol to begin with. And it's this, and oftentimes, patients will present with an estrogen excess symptom-wise, but their levels of estrogen are actually within normal. But what you have to look at oftentimes are the metabolites of the estrogen because of their biological activity, because they're going to be active until they're finally taken out of the body, which means you have a bunch more active estrogens that are not being measured on your testing, and it leads to a lot of the symptoms. Likewise, over the course of years, the integrative medical crowd has recognized a lot of these and said, yeah, well, we have a lot of strategies to help in the liver metabolizing and detoxing these estrogen metabolites effectively. The question that I always like to propose is, well, all right, well, what happened to those enzymes to begin with? Why did one person's enzymes to metabolize estrogen all of a sudden become deficient? Why are they no longer able to handle the overall load? And these are important questions because ultimately, people oftentimes aren't completely deficient in the enzymes themselves, although we'll talk about some of the mutations that may lead to that. But oftentimes, and more commonly, I should say, the liver becomes challenged by some other external force, and their ability to process the estradiol, the estrogens, becomes weakened, and that's where you get the excesses and the dysfunctions. So the symptoms of estrogen dominance are quite plentiful, and I think most of the attendees to this webinar already are familiar with everything from more commonly the PMS and the irregular periods to the endometriosis, fibroids, cysts, thyroid nodules, breast lumps, cellulite, infertility. And what we want to also point out is most of the time, I see patients coming in with endometriosis, with PMS, with fibroids and ovarian cysts. I always in my head will say, this person has about a 75% chance of being positive for SIBO. And I've not and that percentage hasn't changed much in the last couple of years with a lot more testing that we've done to confirm that. It's once again, if you go back in time, when the original therapies that were employed in the herbal world, the naturopathic world, in the functional medicine world, for PMS, for fibroids, for endometriosis, oftentimes were based on normalizing the estrogen levels and activity and supporting the liver directly, and to dietarily take people off of dairy. Eventually, as gluten became a little more villainized, both for good and bad reasons, it became more of a trend to go both gluten and dairy free. Well, once again, many patients reported back that the results that they got from the dietary change made more impact than any other therapies that were employed. And of course, if they were cheating on the diets, they'd have more of the instant feedback in regards to symptoms. And I don't think that's a coincidence. Once again, the gluten, the dairy, those are some of the best fertilizers of the bacteria that lead to SIBO in the gut. So over the years, certain therapies have been put in place, and clinically, I've adopted a number of them that I find to be extremely effective. Both they're cost effective for patients, they have direct results. We also know their mechanisms really well, so we can manage them very easily, and they don't often lead to side effects. One of them, which is a product called calcium D-Glucurate, has been around for a very long time. It promotes the phase 2 glucuronidation. Basically, in that phase 2 process, you take some toxic molecule or a molecule it's metabolizing, and you're making it water soluble. Which, of course, for going from phase 1 to phase 2, that's makes it basically more toxic. And your phase 2 then gets that out of the body. Well, the calcium D-Glucurate has been shown to help prevent the reabsorption of detoxified estrogens through that second pass metabolism. And it has been also been thought of, and in some studies looked at as a potential beta-glucuronidase inhibitor. And this is really important because if a person has an estrogen excess, whether it's because they have too high of an estrogen load to begin with, or they have higher levels of the harmful estrogen metabolites, preventing the reabsorption of them is key to help providing some instant improvement in patients, because you're just taking that harmful estrogen molecule, that potentiated estrogen molecule, and keeping it from recirculating over and over and over again. It's a great therapy to use with excessive hormone levels or the increase in estrogen, especially the estradiol metabolites, and of course also with environmental toxic exposure. So any of your xenobiotics, things that look like and act like estrogen in the body will do the same thing. Hence, the glucuronidation pathway for some patients can be blown out. I remember very much one of my very first patients I ever put on the calcium D-Glucurate was a little on the OCD side of things, and she only ate her fruit out of tin cans. And it just sounds a little strange, and she ate. This was in New England. I'm going to preference this. This was New England. New Hampshire people are a little quirky. But she was eating fruit cocktail and fruit out of tin cans at work every day. She was a pharmacist and was very busy. Her tin level on her metal challenge test was just through the roof, like just an astronomical high amount. And she had horrible irritability, horrible cycling problems, to the point where she came to see me and said, "Hey, I have 2 weeks to get myself together, or my husband's going to leave me. He can't handle it anymore." This is also the same person who told me that she has assaulted numerous people for drawing her blood just as a reflexive reaction. I said, "Oh wow, this is a very interesting patient." Likewise, it was interesting because she could not tolerate most treatments. The one treatment she tolerated and she flourished with was calcium D-Glucurate, helping that glucuronidation pathway, which completely got knocked out from either the metal load or some other load that she was challenged with. But it was a game changer for her. I keep that memory in the back of my head because it's a good illustration on how one pathway can make a difference between having your stuff together and not having it together. Diindomethane, this is another nutritional supplement that has been around now for over a decade and a half. Diindomethane is used to stimulate the 2-hydroxylation pathway via the CYP1A1 pathway. So it's a kind of a neutral estrogen pathway. It reduces expression of the 16-hydroxylation through inhibiting the CYP3A4 pathway. So the 16-hydroxyestrone is a very harmful estrogen, and we don't like 16-hydroxyestrones in high amounts. That's usually, it illustrates people with high risk for not only estrogen excess symptoms but also estrogen dominant cancers. We don't like those. So once again, the DIM helps in the metabolization of the estrogen metabolite, so it can actually be removed out of the body. And it's very effective at reducing harmful estrogen metabolites. If I remember right from back when I helped, when I was around when this was first launched, you can see up to a 70% reduction in those estrogen metabolites in about 2 weeks. The way that I tell my patients when I put them on it is that the first month, the first cycle you have on DIM, you're going to feel an improvement. You're going to have more improvement from that first cycle to the second cycle. After that, your improvements with DIM are pretty much capped off, and so whatever improvement you have at that after that 2-month mark is pretty much what you're gonna get out of it. So you can determine whether or not it's enough of a help to maintain a little more long term. And of course, with diindolylmethane, is a nice little illustration just showing how it helps in promoting more of the metabolism of the less biologically active metabolites and helps in preventing the more harmful ones, the 4-hydroxyestradiol and the 16-hydroxyestradiol. And so it does this very effectively. Now, once again, if you're performing this activity using DIM or calcium D-glucarate to lower the harmful metabolites, one question I always remind people is like, don't forget, we need to look at the root cause. Why is that challenged? And someone just texted and asked, hey, do you recommend the diindolylmethane through the entire menstrual cycle or just during the luteal phases? When I first start with patients, I use it for the first 2 months straight. And then after that, depending on where we land with all the other treatments, I either start scaling it back to once during the luteal phase. Sometimes we even try to minimize it just maybe the week before menses. Once again, if you are working with a patient, their total load of estrogen metabolites that need to be addressed by DIM will decrease if the root cause behind their problem is taken care of. So let's talk another level of this. So in the whole phase 2 kind of estrogen detox world, you're looking at estrogens, and there's about 9 different genes that affect estrogen detox. And I'm going to tell you right now, I am not going to talk about all of those because that is an entire weekend-long seminar in itself. In addition to that, clinically, when we're working with patients with SIBO, and especially when it's SIBO with anxiety and PMS and cramps, etc., we often see COMT as one of the main issues. Now, yeah, there's lots of other issues that can occur upstream, but that COMT mutation is something that I don't, even though it's well known and is talked about a lot, it's not treated as a primary issue, I believe, enough, and it leads to a lot of excessive treating for other things, including the anxiety and even the estrogen excesses. So in phase one detoxing for estrogens, it's hydroxylation, and that's where you get your CYP enzyme that could have a play in that. And I think a lot of people are doing a lot of genetic testing, and they can see if someone is predisposed to then maybe not having a good CYP enzymatic activity for those functioning. The phase 2 part is the methylation part. And the methylation part is covered by just the COMT enzyme. And, you know, when someone has a MET mutation on their COMT enzyme and they have SIBO, it's like pouring gasoline on a fire. You just fed a fire that wanted to burn, and it'll keep burning, and oftentimes takes hold of the patient and their entire life. So if you're not familiar with COMT, that's your catechol-O-methyltransferase. The enzyme itself, it's sort of like a Hoover vacuum where it sucks up the catecholamines. It helps metabolize or break down the catecholamines. The catecholamines are your excitatory neurotransmitters, your dopamine, your epinephrine, your norepinephrine. It is a really interesting and cool side note. It also adds methyl groups to compounds having those catechol structures, which includes all your catechol estrogens. And they help, not only do they help regulate these excitatory neurotransmitters throughout the body, they especially have a lot of function in the prefrontal cortex of the brain. And that is an area of the brain that's responsible for a lot of your personality traits, your inhibition of behaviors, your abstract thinking, and your emotion. And so in a lot of my lectures on neural balancing, I'll often talk about the prefrontal cortex as a very important area, especially for the fear and anxiety emotions. And you often will see, people with a imbalance in that prefrontal cortex, not only having the brain fog, they'll have the horrible fear and anxiety that also gets translated to a lot of those other ugly emotions, the jealousy, the rage, the irritability. So once again, a imbalance in neurotransmitters can reflect quite greatly through the body. And what's of course with that, catechol-O-methyltransferase mutations have been studied probably as much as just about any other gene mutation. And they've shown to be directly correlate with anxiety issues, especially family inherited anxiety issues, including phobias, panic disorders, addictive behaviors, neuroticism. You have your overall, the COMT takes your catecholamines and then they metabolize them. And I know that a lot of people do some organic acid testing, and they'll often look at the metabolites of the neurotransmitters. I still recommend people to measure your neurotransmitters directly, because once again, you're assuming there's a direct correlation, and they're not. Sometimes that doesn't always happen, especially if you have a COMT mutation. You can have a significantly higher dopamine and a much less of its metabolite. And likewise with the norepinephrine and epinephrine. So when you have, there's two sets of mutations that you can have with a COMT. You can, the average person is heterozygous with a MET-val standing. But when someone has a MET mutation, a MET mutation is basically leads to a decrease, a 2 to 4-fold decrease in catechol-methyltransferase activity. When you have that decrease, that basically says, if you have that decrease going on, that means your estrogen levels are already at a higher point, taxing the liver. And so, your liver is going to be challenged no matter what. If you throw something else in the mix, it could oftentimes tip the edge. That's why we see such a strong correlation clinically with the COMT MET mutation and SIBO and anxiety. And I think that's an important thing to factor in with how you work patients up, because when you have a female with some estrogen dominance issues or other estrogen issues, and they have the anxiety and depression, sleep issues possibly, you should put that, making sure you get their COMT status at the very high top of your list of tests to recommend. What's interesting, in one of the studies, they showed that stress, both mental and physical, can result in more comp changes in women versus men. So once again, if a female with a MET mutation is stressed out, and a male has the same equal stress, because of that COMT mutation, both on a physical and mental side of things, the women will actually be more challenged than men. Once again, a big part of that is because of the effect that COMT has on estrogen levels. So one of the things I wanted to highlight is in my clinical experience, I have not found anything to work better than SAMe in supporting the MET COMT mutations. And I find, once again, when someone has the estrogen excess along with the COMT mutation, leading to issues both with either anxiety or depression, the ability for SAMe to work can be absolutely brilliant and life-changing for those people. And so it's a great way to help in identifying a root cause problem. Because, hey, if you have a MET mutation, you have a 2 to 4 fold decrease in COMT activity, you need to do something to boost it up if it's interfering with your life. You know, some people are revving just fine and they're able to compensate and handle their COMT mutation because, let's get realistic, a good 20%, 29% of the population might have MET mutations. Not everyone is dysfunctional. I guess that depends on who's describing that. But the one of the things to highlight here is, once again, if they have a MET COMT mutation, SAMe has been shown to be one of the few things to help in upregulating COMT activity versus just about anything else on the market. SAMe is mostly concentrated in the brain and liver. Directly supports 3 different pathways: your transmethylation, transsulfurization, and the transamino propylation. Transmethylation pathway is one of those things that I've been interested in all my life because that's the pathway where SAMe boosts levels of serotonin, dopamine, and norepinephrine in the brain. And it's a very effective product when needed. In addition to that, so in the dosing and how we look at helping with estrogen metabolism, and I imagine a lot of these practitioners on the webinar today have a lot of their own tricks up the sleeves that they've been doing. Feel free, you can always text and give me some of your suggestions. I'm happy to share it with everybody in the audience. And with that, I like to use SAMe in the 200 milligram between 1 and 2 caps each morning. Now, if you are looking at people, when you're if you're identifying other methylation issues, such as MTHFR or B12 issues, what have you, your dosing for SAMe will not be as great as if you ignore those. And I say that because in the literature, in a lot of studies, they've used SAMe for patients for depression and whatnot, and the dosings can go up to 1,200 milligrams a day. And I do have some patients that do better at a little bit higher doses, maybe even 600 milligrams a day, but they're more the exception than the rule. Although if you read the literature, you'd think that it'd be more the rule than the exception. I think a big part of that is, once again, SAMe helps greatly with the methylation cycle, but there's other issues with the methylation cycle that may be happening. So if you're addressing all of them, the daily dose of SAMe, more times than not, is just 200 milligrams, and sometimes up to 400 milligrams. Obviously, synergistically, we like to use diindomethane at about 75 milligrams daily, sometimes just 50 milligrams, just depending on the person. Calcium D-Glucurate, for the average person that doesn't need a huge amount of help, 200 milligrams is very synergistic with DIM. If they are more challenged, especially if they have more symptoms related to the estrogen levels, estrogen excess, then we increase it. And 600 milligrams is a good dose. I have done higher doses up to 1,200 milligrams in some patients, more short term, until we can get a grasp, a handle on the reason behind the estrogen excess. We also, other additional anxiety support, because many times when you have a scenario of estrogen excess and the MET mutations, you often have anxiety as a main problem. Just like in SIBO, you see many more people with more people than average with anxiety with SIBO than you do with other mood disorders. 5-HTP, 100 to 200 milligrams at bedtime. Now, if the people are really raging with lots of anxiety, you could even include the 5-HTP 100 milligrams in the morning too. One thing to note, 5-HTP is your direct precursor to make serotonin. And serotonin and dopamine, they kind of share the same rate-limiting enzymes. So if you have a hard time breaking down your dopamines and your norepinephrines in the daytime and you're revving with anxiety, a little 5-HTP to make some serotonin can help pull a little bit of that aromatase decarboxylase out of the body and prevent the dopamine to use it. So it might help reduce some of that dopamine activity also. So it's a nice little play. Once again, it's nice to do a little urinary neurotransmitter test to just double check to make sure that that person's serotonin is not in a very high level to begin with, which could happen in some situations, especially with anxiety. A phenylated GABA is really good as a band-aid approach to help boost GABA activity. And that's usually anywhere between 100 and 600 milligrams daily, depending on the person. Once again, hopefully it is just a short-term use and not a long-term use. Other thing I like to look at is bioinositol, 1 to 2 grams daily. Use it especially if you have kind of the SLC6A4, which is a serotonin transporter mutation. Those particular patients, they're poor candidates for both SSRIs and 5-HTP, but they do relatively, oftentimes can do really well with myo-inositol. And likewise, there's been some write-ups and studies looking at myo-inositol with polycystic ovarian syndrome. So here's a little case study. There's a 16-year-old female with PMS symptoms, cramps, bloating, the irritability, the mood, anxiety is a common ongoing problem. Nausea, abdominal pains, acne, and the irritability was one of the main problems because it was irritability at everybody in the house and at school, which led to some number of disciplinary issues. When we did a genetic test, her COMT, the 158 gene is the most dominant COMT gene. The other COMTs are minor players. There are some studies looking at some of them. Most of the studies are at the 158 gene. So just remind you on that one. I didn't include the whole hormone test here because I wanted to just highlight with her the level. These her harmful metabolites of estrogen, the 16 and 4-hydroxyestrogens, were both much higher than they needed to be. As you can see in the nice little graph that the lab created to help highlight the level at the activity level of the good versus bad metabolites, you see a better representation of, yeah, that's not good. That's a lot of bad metabolites. And this one, not all that great, could be better. Once again, she presented with a lot of the estrogen excess. This is a confirmatory that it's happening. Now, is it necessary to do a metabolism report with every person in order to actually put the products in? No, it's not. And we don't always do that. We do that oftentimes if we're interested in knowing what the big picture is on the hormones. At the same time, depending on patients' finances, we may not do some of the testing because, especially with like calcium D-Glucurate and diethylmethane, they're so effective so quickly that they often help in sometimes a little trial to determine if that is a problem or not. In this particular patient, she did her lactulose breast test. Her test levels, they were that good. She started off at high 22 parts per million hydrogen, and quickly went to an easy positive 62, and an increase of 40 parts per million. I think I'm getting a few people saying that there is a audio issue. I'm just going to double check here. Yes, there is an audio issue. Okay, I have no idea why there's an audio issue. Let me just check everything. 1 second. Okay. Okay, I'm just reset it a little bit. Can you text someone, give me a text and just make sure that it is working properly? Nope, you guys are still not working. Okay. Keep talking. I think it's just a little bad. Now it is. It's better. Okay, good. We like this. So in this particular patient, the hydrogen was a high baseline of 22. After the lactulose breath challenge, she quickly went up to by 40 points on just the hydrogen alone to be a positive, and of course it was a sustained positive throughout the entire small intestine. The methane wise, she started off at 8 parts per million, which pretty much lets you know that she's going to be positive on methane in the future. And lo and behold, she easily reached diagnostic criteria at 20 minutes with a 15 parts per million. So total bacterial load, when you look at the actual overall combined totals, was a pretty strong, significant SIBO. Not too surprising from her symptoms that she had, the acne, and of course, why does someone's liver no longer process estrogen metabolites? So in her particular case, we started off at 200 milligrams of SAMe, but she did increase up to 400 milligrams. And that was pretty easy to determine because we have treated the rest of the family prior to this, so sister and mother and father, and sister and father, they are the ones with the same MET-COMT mutation, and lo and behold, they all do better at a little higher dosing. We had the initial dosing of the DIM at 75 milligrams, and for efficiency's sake, I just used a combo product that had the DIM and the calcium D-Glucurate together, so it was just a 200 milligrams of the calcium D-Glucurate that she got. In addition to that, because of the irritability and the issues she had at school, we did put her on some phenyl-GABA at 100 milligrams only in the morning, and that helped calm things down rather quickly. For SIBO treatment, we put her on my methane protocol, which was basically 2 weeks of herbs, which she was a trooper with. So they like to do things as natural as possible. And so she was pretty used to taking supplements. So 2 weeks of the SIBO herbal protocol she was okay with, and then 4 weeks of the antibiotics. If you're not familiar with my protocols, then feel free to check back at one of our future webinars in treatments. This particular patient, she responded extremely well to the treatment. So that's not too surprising if I used her for as a case study. When it came to the need for DIM, she sometimes now goes off the DIM for a month or two before she just takes it for another few weeks, and that she just helps regulate herself that way. The SAMe is a indispensable item that she finds pretty much keeping her life in a much better place. She only uses the GABA, the phenyl GABA, as needed if it's a real stressful week or has some test anxiety, but otherwise it's used much less. And when it came to the SIBO, she actually responded extremely well to the treatments, which made all the family very happy. We had another 31-year-old female with a mixed irritable bowel. She also had PMS, lots of migraines, joint pain, fatigue, insomnia, a neuropathy, little sensations in the arms, radiating down the arms, and anxiety. Once again, I didn't want to bore you with the overall hormone levels. In her particular case, it's interesting. Her levels were slightly high in the estradiol, I believe, and the progesterone. And downstream, her estrogens didn't look too bad. They were still on the higher end of normal, but her metabolites were much greater. So it definitely put her into a pretty high estrogen excess phase. When we did her SIBO testing, she had a pretty high baseline level, so definitely not a baseline that I like to see in patients. Ideally they're between 0 and 3 parts per million for a total baseline. In her particular case, you had 13 on the hydrogen, 8 on the methane. She did a lactulose challenge test. She kept retesting every 20 minutes. The total level dropped just a little bit down to 18. Then it started going back up and became rather significant at 80 minutes with a clear diagnostic positive for both hydrogen and methane. And of course, once again, when patients have a methane dominant SIBO, you tend to see a little bit more symptomology. When you tie that into a really high hydrogen in general, then you just pretty much are, as I said before, throwing some gasoline on a fire, especially if they have any type of genetic issues. Now, in other labs of interest with this 31-year-old female, she had a high normal estradiol, elevated interstitione, and some cortisol metabolites. Her urinary serotonin was very low. One thing to remember is, like, if you're having migraines, 1/3 of the causes of migraines are often low serotonin. You got to remember, we think of serotonin for mood, for sleep, for other things, but one of the main functions it has in the blood is to help keep vasotone and to help keep your blood vessels nice and flexible and not constricted. When you have very low serotonin, you're always going to be more prone to having migraines. And so if you have a migraine, if the person can't test for serotonin activity, you should assume that they have lower serotonin and do just a low dose of 5-HTP and maybe gradually increase it, or do a urinary test and double check on that. Myeloperoxidase, which is a serum test, we ran that, and that was 821. That's really high. Now, this is a person with no cardiovascular problems, so we don't expect myeloperoxidase to be elevated for any cardiovascular disease. It's often the increased neutrophilic activity in the intestines, and of course, we see that correlate with SIBO a lot. Now, you can have elevated MPO due to intestinal problems that are not SIBO. In this particular case, it was definitely SIBO, and just a slightly low vitamin D, which you see a lot of fat-soluble vitamin issues in people that have had long-term SIBO. In her case, 5-HTP, 100 milligrams at bedtime, was really all she needed to help boost her serotonin levels, to help start reducing the migraines. Diindolmethane calcium D-Glucurate, I used a higher dose, 600 milligrams of the calcium D-Glucurate this time around, because of not only, well, one, she had the migraines, and two, she had all that estrogen excess that we saw with higher normal levels of estrogens. So we just thought we add a little bit more, reduce a little bit of that recycling of the estrogen metabolites. Vitamin D, we just do our typical vitamin D dosing to help reboost that up. SIBO treatment, once again, in her case, we did the methane protocol as an adult. We kind of tormented them a little bit longer than we do with our younger kids. 4 weeks on the herbs and 4 weeks on the antibiotics. Post-treatment, because of the high neutrophilic activity that we saw with the myeloperoxidase, we did a post-treatment, a little extra gut health support with some L-glutamine powder, vitamin A, and some liquid live probiotics. Last case study here. Here we go. I got a couple questions. I think that responded back here. Let me go back one slide. One of the questions that we have from an attendee is on a CBC. If someone doesn't have more extensive testing, do you expect to see neutrophils to be as high with SIBO? The answer is no. You sometimes can, but usually you do not. It's not that sensitive, and what you're going to see is that neutrophils are going to be concentrated within the tissues themselves. And so they're going to migrate towards the area of problem. So hence you'll see the myeloperoxidase elevated, which is the enzymatic activity that is then circulating. You're not going to see the actual neutrophils around because they're hankering down in the intestine typically. When people do colonoscopies, oftentimes if they do some biopsies, they might see the remnants of that as like a neutrophil infiltrate, and oftentimes it'll just be a side note where it's like, yeah, it's a neutrophil infiltrate. It's not bad. It might be something in the past or something minor. Oftentimes you can often see it as, yeah, the activity of a SIBO too. Someone asked also about the vitamin A. Why do we use vitamin A in a gut treatment? Vitamin A is retinol. Vitamin A is a rate-limiting factor in the synthesis of tight junctions. And there are, the nutraceutical industry has created thousands of products to help with gut health, with leaky gut and whatnot. There's many different things you could use, from your zincs and whatnot. Ultimately, pound for pound, dollar for dollar, using L-glutamine and vitamin A are your two essentials that, to me, after that you build off of. And between feeding the epithelial cells and then helping improve their tight junctions and to help further the epithelial growth, it's an easy 1-2 punch. So a 28-year-old female with constipation, PMS, abdominal pain, fatigue, and multiple food reactions. Constipation started after childhood rounds of antibiotics for ear infections. So, all right, that starts looking pretty obvious. I mean, one thing in your head, and you hate to like assume anything, but all right, if you got a bunch of ear infections as a kid, all right, you probably got a dairy sensitivity until proven otherwise. And then your constipation started after rounds of antibiotics. All right, well, once again, kids should be going to the bathroom, and if they're not, there's something really wrong with them. She herself started her job, will be starting a new job in 4 weeks, and she's been having some financial issues. So it's like, all right, we do the test, and she came up, baseline measurement of hydrogen was like, what, 34? And then it dropped down to almost nothing. Baseline of methane was 37, which is diagnostically positive for SIBO, and remained positive all the way through. 120 minutes, probably where it dropped into the large intestine, was extremely high at 81 and even all the way through. So very high colon activity, very high small intestinal activity. All right, and you're financially a little strapped. You're about to start a job in 4 weeks, which you can't miss. So what do? All right, well, we've kind of withheld a lot of the other testing because of the cost and expense. We put her on a combo product that was 50 milligrams of DIM and calcium D-Glucurate. We had her do a bare minimum, the lowest cost possible allicin product and oregano oil that I could find to target not only the SIBO, but also any of the fungal overgrowth that we know usually is around with SIBO, so that then when she started her elemental diet, if we kind of knocked out a little bit of that yeast, she would be less prone to thrush or yeast overgrowth. And then she did the elemental diet for 2 weeks, and she immediately retested. She did 14 days diet. She fasted overnight, and then on that 15th day, right before she broke her elemental diet with food, she retested. And lo and behold, a significant improvement. I still don't like seeing a methane level of 7 at 20 minutes or 6, but once again, she kind of like climbed Mount Everest really quickly with a very aggressive approach. Not everyone will respond that well to an elemental diet, but in this case, she did, and she did a really good job with it. So we're going to finish up right now. We have a couple more minutes left before the end of the webinar. Just a little highlight. One of the things is to rule out SIBO before maybe even considering some hormone metabolite testing, especially if it's cost prohibitive for the patient. So once again, do you look for something that you know is probably a problem, or are you looking for the root cause behind the problem? And so a breath test, either a glucose or lactulose breath test, is always a good possibility. So hence, if you're looking at root cause problems, breath test should be ruled out kind of first, and then consider then your other hormone testing, whichever camp you like to fall in, with a 24-hour, a Dutch, a salivary hormone, whatever it may be. You can then do your testing to figure out after the fact. But once again, because of the effect that the liver has on the hormone metabolism, it's very efficient or effective oftentimes to treat the known problem on the front end, and then, hey, they still might have some other hormonal issues. Yeah, let's clear up this problem first so that you can actually have a better view of what else might be left to be taken care of. Then you could focus in your treatments in a much more targeted fashion. All right, it wouldn't be a great webinar hosted by a company if we didn't do a little bit of shameless promotion. So if you are not currently a Neurovana account, we'd love to have you join our Neurovana family. Feel free. You can set up an account with a new order form. You can find that on our website or contact us. We can send it to you. You fax your requisition form or email it over to us, and then we'll process and drop ship the collection kits to your patient usually within a day. The patient collection materials are mailed out via our U.S. mail. We only use the Quintron branded equipment and materials, so you have the best materials in the industry. Not every laboratory does that, so we're happy to offer nothing but the industry standard. Patients will receive the intake form and all the collection materials. It's an easy process for them to do at home. One of the things that makes us at Neurovana stand out, we like to offer, we have two doctors who are actively practicing SIBO docs that see a lot of patients and work through a lot of issues. We're happy to walk through your test results and your cases with you. We're happy to share what we've learned already with you. Some of the big take-homes is that the small intestinal bacterial metabolites can challenge liver function. Estrogens are metabolized by the liver and can be affected by SIBO activity. Treat SIBO and address hormone imbalances is always a good approach, and rule out the COMT mutation, especially when there's mood issues factor in here. All right, if you liked what you heard today, or if you're looking for a little company when you are eating your lunch, our next webinar is going to be next week, April 25th. Feel free to register today at our Neurovana website. It'll be our part one of our intro to SIBO, why you want to test and how to test. And once again, I think I have a couple more questions that I did not answer. Real quickly, I'm going to answer this one right here. How can we order hormone-related genetic testing via your company as well? I'm sorry, we don't offer that. We're just a SIBO lab. When it comes to genetic testing, there are a lot of companies out there. Many people choose some of the patient direct online companies because they are the most cost effective. Some other labs do offer hormone testing. And I would just start asking your fellow colleagues for some options. All right, well, with that much said, I went over a couple minutes, and I thank everyone for joining us. Once again, we appreciate you for being here. Please register for our next webinar, the Introduction to SIBO Part 1, what, why, and how to test, which will be broadcast live on Wednesday, April 25th at noon Central Standard Time. If you need to set up an account or have any other questions, please contact our sales department or drop us an email. Thank you again for joining us, and we'll see you next time. Have a great one.